Okay, I think it is 8 a.m. So thank you so very much for coming to this bright and early didactic at 8 a.m. We are touched and honored. We are going to be discussing approaches to hunger or developing emergency department-based programs to address food insecurity. We'll start with some introductions. My name is Gia Emma. I'm one of the PGY3s in the Harvard-affiliated emergency medicine residency at MGH in Brigham.
My name is Diane Bongiorno, also one of the PGY3s in the HAMMER program.
Good morning. My name is Lindsay Walsh. I'm one of the PGY2s at the HAMMER residency program.
Hi. Is this one working? Maybe? No?
It's not.
Now it's on. Good. This was a test. Danielle Cullen. I am a physician researcher at the Children's Hospital of Philadelphia.
Jason Morris, also a PGY3 at the HAMMER program in Boston.
Maggie Simascalo, physician researcher, health services researcher, whatever you want to call it, at MGH in Boston.
All right, wonderful. So we do not have any disclosures. We have a couple of objectives today. So we wanted to describe the impact of food insecurity on health outcomes and specifically explore how it impacts our patients in the emergency department, to expose you all to some innovations that are happening around the country in the kind of realm of interventions on food insecurity in healthcare settings. And then finally, to use food insecurity as a lens to explore some of the challenges of interventions on social needs and research on those interventions in the ED. So we are, as you can notice, a lot of residents and really thrilled to be bringing this to you under the mentorship of some faculty who are real experts in this field. So for the first half of the talk, where we have a bunch of slides for you, but for the second half, we were hoping to just collaborate and brainstorm together about how we might be able to advance some of these efforts at your institutions. So there will be some small group discussion despite the kind of architecture of this room. So please feel free to kind of come up if you'd like, because that will be what we'll transition to later on in the talk. All right, so we're going to start by discussing food insecurity and health outcomes. To begin with some definitions. So food insecurity is a household-level economic and social condition of limited or uncertain access to adequate food. And when measured by the USDA, it has two tiers. The first tier describing kind of reduced quality, variety, or desirability of a diet. And then with the kind of second higher tier, really describing multiple indications of disrupted eating patterns and reduced food intake. And food insecurity can, as you can imagine, lead to hunger, which is a condition of prolonged involuntary lack of food that can result in discomfort, illness, weakness, or pain that goes beyond the usual uneasy sensation we describe as hunger. And unfortunately, food insecurity is quite prevalent in the U.S. population. So, as mentioned, the USDA provides a supplement to the Census Bureau's survey to assess food insecurity in the U.S. And in 2022, they found that almost 13% of households endorsed experiencing food insecurity. That represents 44 million Americans, including 13.4 million children. And of the general population, actually 5% describes very low food security, and so actually reduced food intake, representing 1% of households with children. And unfortunately, kind of social vulnerabilities that already negatively impact patient health outcomes, as you can imagine, also exacerbate internal disparities within the population that experience food insecurity. So Black and Latinx households are almost twice as likely as white households to experience food insecurity. American Indian and Alaska Native populations experience rates around 25% of food insecurity. 36% of households with an adult who has a disability endorse food insecurity, and then 13% of household or people who are LGBTQIA described food insufficiency, which is actually a more severe metric describing inadequate access to food over the last 7 days. So as you can see, really kind of the intersections of different vulnerabilities can really compound the impact of this problem. Food insecurity adversely impacts health outcomes really across the lifespan. This is best studied in children, but we see it with adults and the elderly as well. In children, food insecurity can be related to birth defects and developmental delays. It is related to increased rates of viral infection, of developing anemia, asthma, mental health challenges such as behavioral dysregulation, anxiety, depression, suicidality, and it's related to kind of poorer academic performance. In adults, food insecurity can be related to poor sleep and the development of vascular risk factors like hypertension, hyperlipidemia, and diabetes. And in the elderly, we see, in addition to the above, it's related to the development of heart disease, increased rates of hospitalization and longer hospitalization, and then limited ADLs. So over the last several decades, public policy and research have really recognized the increasingly important role of the emergency department in the care of socially vulnerable patients, and that's, of course, because those are the patients who are showing up at our doors. So studies show that between 14 and 25% of ED patients experience food insecurity, and you'll note that this is significantly higher than the general population of the U.S. And ED patients experiencing food insecurity often describe having to make the choice between food and medicine, with food insecure patients often saying that up to 20% of the time they'll choose food over medicine, which, as you can imagine, has the potential for exacerbating other health outcomes. And a really illustrative case for how food insecurity can lead to increased ED utilization is the case of diabetes. So the literature shows that patients with diabetes endorse both foregoing food in order to buy diabetes testing supplies and medications, and also foregoing buying testing supplies and medications in order to be able to buy food. Of course, when somebody is continuing to use medications in the setting of food scarcity, that presents the risk of developing hypoglycemia, and we do see that patients with food insecurity present to the ED with hypoglycemia at rates much higher than that of the general population or the food-secure population. There was a really interesting study that actually demonstrated that there's a monthly cycle to hypoglycemia-related food visits for low-income people. And the researchers hypothesized that, at the end of the month, people's food budgets tend to run out, and that is actually when we're seeing increased visits. The study actually looked at 11 years of data and over 500,000 patient visits. And interestingly enough, in that time, there was an economic stimulus that provided supplemental assistance for nutrition, which mitigated the impact of this kind of cyclical, or of this cycle, which really further reinforced the idea that food insecurity can lead to exacerbations of these chronic problems. So now transitioning to ED interventions that have addressed food insecurity, just to start by stating the obvious, of course, the solution to the problem of food insecurity is not housed in the emergency department. We can get into in the QA section where it might actually be housed, but there is actually a lot that we can do, both connecting patients to existing resources outside the ED, to leveraging external resources, bringing them into emergency departments to address hunger for our patients, and then finally, really just establishing the ED as a place where patients can come and build trust with this patient population, supporting the full spectrum of their health. We're going to discuss a range of interventions going from lighter touch interventions, which by that we really meant just kind of easier interventions to get off the ground vis-a-vis resources, and then move up to heavier touch interventions, which either require more resources or have a huge impact. So for light touch interventions, we're going to start by discussing screening and referral. And I'll start by just emphasizing that there are a number of programs that we can refer patients to. So there are a number of federally funded and state-funded programs that address hunger in the United States. The biggest one, as I'm sure you might already be familiar with, is SNAP, or the Supplemental Nutrition Assistance Program, also known as food stamps, which provides monthly funds to buy groceries for low-income people in America. But there are also other programs, such as the Emergency Food Assistance Program, which is a nutrition program that moves food from farms to food banks. Sorry. There we go. Farms to food banks. The WIC program, the Women, Infants, and Children program, which provides funding for women and children up to age 5 who meet income eligibility requirements. Through the Older Americans Act, the federal government also provides funding to states to provide food via home-delivered meals, such as Meals on Wheels, or meals in congregate settings. They also provide funding for food in child and adult daycare programs. So really there are a number of resources in the community. And unfortunately, there's a gap between eligibility and utilization of these resources. So around 8 million people are likely eligible for but not receiving SNAP benefits. And there are a number of barriers that could explain this gap, including the lack of awareness of eligibility, stigma, and then really just lengthy and complicated enrollment processes. A study of ED populations actually demonstrated that, our specific patients are under-enrolled. And so this is data from an urban academic emergency setting, and they looked at patients who were enrolled in Medicare, Medicaid, or were uninsured, and found that of this population, this population was only utilizing 30% of the benefits for which they were eligible of the 15 that they surveyed for, including 32% of the population which was eligible for SNAP but unenrolled in that benefit. The real opportunity, though, that they highlighted here was that many people were either interested in applying for future benefits, and then specifically they were amenable, 74% were amenable to getting help from a hospital-based team in enrolling for these benefits. All right, so I'll be brief on this because at a later point in the discussion, we're actually going to dive into some of the opportunities and challenges on conducting research in this setting. But we'll say briefly that most of the research on screening and referral that we were able to encounter so far has focused on process outcomes, so such as like the number of referrals that were made or the utilization of those resources, which do demonstrate a kind of modest uptake of resources ranging between maybe like 30 and 75%. In other important kind of realms that we are interested in, right? So like the impact of our interventions on the status of food insecurity, on health behaviors such as intake of fruits and vegetables, on actual health outcomes like rates of hypertension and diabetes and healthcare utilization. The data is slightly more mixed on what it shows for screening and referral thus far. A number of medical societies, including the AAFP, the American Academy of Pediatrics, and then our own professional association, the American College of Emergency Physicians, now are starting to recommend screening for social determinants of health and specifically food insecurity. And we're starting to be incentivized financially to screen for social determinants of health, including food insecurity. So CMS now has a standalone billing code that will pay for administering a risk assessment every 6 months. And as we all know, the 2023 changes to our own billing guidelines can increase medical complexity of the chart when we document food insecurity. And so to think through some of the kind of implications of screening without intervention, and also to think about like how we should be screening, I'm going to turn it over to Dr. Cullen and Dr. Samuels-Kalo.
All right. So this part where we're talking is going to be a little bit less formal, and considering that we have, a close-knit group here with us this morning, is there anything in particular that would be most useful for you all to hear about that kind of brought you here in the considerations of how do we do this screening? How do we intervene? Anything that you're hoping to hear? I know, it's super early, except many of us came from the East Coast, so it's midday for us. Okay, well, in terms of all of the background that you heard, we now have the level set for us. We know what food insecurity is. We know that it's now incumbent upon us by policy pressures in order to screen for and address these things. But kind of questions that come up in our minds about this is, we don't have the solutions. We don't know the answers. We don't know how much of a difference we're making. We don't know how to measure the outcomes, and that's a lot of what we're going to be talking about today. So things that come up in my mind are we screening for the right things? Is this screening actually ethical? Are we able to elicit what it is that that patients, in my world, because I'm in the pediatric ED setting, families actually desire? So that brings us to the difference between social risk and social need. So these factors, when we talk about social determinants of health overall, that's really discussing the structures in which people live, work, learn, grow, play, their community setting, these upstream factors. Social risk, what we tend to screen for, food insecurity, is material hardship. At the individual level. Social need, on the other hand, takes into consideration more about priorities and preferences of what do you want assistance with. So as we're thinking about screening for all of these factors, some things that I would encourage you to think about in your own practice or in what you hear throughout the course of today and what you see being done is, are we eliciting just whether it is that our patients are meeting some sort of threshold that we're giving to them based on a screening tool to deserve the intervention that we have, or are we allowing individuals to set priorities for what it is that they want help with, regardless of whether they meet that threshold? You just heard a little bit about these requirements and billing codes and reimbursement being tied to documentation of these social risk factors. And what I would also challenge and kind of offer to everybody as an opportunity for advocacy is the consideration of whether this actually creates a little bit of a perverse incentive, where we're getting reimbursed for how complicated our patients are without any actual requirement to demonstrate that we're intervening or trying to do some good in the lives of the patients that we're serving.
So in particular, this was a real missed opportunity, I think, in the way that the EM billing and coding changed about 1.5 years ago. Those of you who are practicing emergency physicians know that you now can upcode your charts if you discuss social determinants of health in some way, and how that increases the complexity of the care that you provide. But it doesn't actually require you to do anything about it. It just requires you to say that they're there, and you get this financial incentive. And I feel like there's a missed opportunity there to have required the offering of intervention in order to qualify for the financial incentive that might have potentially helped us make some of these programs more sustainable in the long term. And many of the CMS and state programs are built on the same model, where what they're incentivizing is screening and documentation of screening rather than the offering of any intervention or help. And so what we end up with is very high rates of screening and very low rates of any offer of intervention. And we've seen that in data across our health system and others. And that is a true missed opportunity and an opportunity for advocacy for us as practitioners, as policy advocates, and as clinicians.
I will also share, if you wanted to go to the next slide, we can talk about a little bit of what's on here, and I can't see the slide, so I'm not going to actually follow it. But in the pediatric setting, a lot of these policy statements from our national organizations came out earlier. So we've been grappling with this for the past decade, and I will tell you that we still don't have all of the answers. But we do have is an emerging and growing literature base to identify some of those best practices. So in terms of best practices, especially when we're considering these lighter touch interventions, so some sort of screening and intervention, is that first and foremost, if there is going to be any screening done, make sure that first you focus on what that intervention is. If it's referrals, make sure that those referrals are tailored, that they're geographically appropriate, that they're culturally sensitive, and that patients can bring those resources with them so that it's not something that they're given at a one-time point and then lose access to after they leave the walls of the emergency department. In the emergency department, as you all know, there are lots of competing priorities. So patients are there because they're experiencing what they consider to be an emergency, whether or not that meets our threshold of what an emergency is. But they're having a medical emergency, and it may not necessarily be the right time point for them to receive an intervention. So knowing where they can then access resources at a later point or whom they can contact is important. We were talking about the difference between social risk and social need before. So also thinking about if screening is being put into place, if you're required to screen for risk, ask also, do you want help with that? So include some questions about social need as well, so that we can make sure that interventions are tailored to those who actually desire them. What else did I miss here?
No, that's
No?
great.
Okay.
Wonderful. So I'm next going to discuss a range of what we're calling medium touch interventions, all of which are based in the hospital and emergency department setting. So we're going to talk first about a rooftop farm at a hospital. We're going to talk about 2 examples of food pantries, and then a summer meals program in a pediatric ED. So first is the Boston Medical Center Rooftop Farm, which is a really incredible intervention that provides approximately $18,000 worth of food annually and thousands of pounds of local produce as well. Since this was developed in 2017, it supplies food to BMC inpatients, to the hospital cafeterias, and then also in part the BMC food pantry as well. The Boston Medical Center Food Pantry was the first therapeutic food pantry in a hospital in the United States of its kind. So the majority of these foods do come from the local food bank and are non-perishable items, but during certain times of the year, there is additional food that is supplied from the rooftop farm at the hospital. The model is such that BMC primary care providers essentially can write referrals or prescriptions for their patients to go to the BMC food pantry. And this is designed for patients who have chronic health conditions as well as who are low income. Families can go to the food pantry up to 2 times a month and then receive somewhere between 3 to 4 days worth of food at each visit. And interestingly, it's also a very multidisciplinary team that runs the food pantry, so there's a registered dietitian as well as part of the team to help connect patients to the right types of nutrition for their chronic health conditions. Another example is the food pantry in the emergency department at Norton's Children's Hospital in Louisville, Kentucky. So some differences in terms of this model. In their sort of pilot program, they actually did not screen for need or have referrals. They essentially offered all patients who are in the fast track portion of their emergency department the opportunity to get a grocery bag of food items. And the rationale behind this was to avoid the stigma associated with potential screening of families and the children in the ED. They had prepackaged grocery items that were then stored at the nurse's station, and the grocery bags also contained a brochure of resources in the community that individuals could then access if they did in fact have food insecurity. They ultimately found that just over 50% of those who were offered the grocery items accepted the intervention. A few things to note about their model. There was actually quite a high cost associated with this, so they purchased food from the local food bank and indicated that the cost in their first 15-month period was about $25,000 for the food items. And then a nuanced point around how they avoided screening was that they also were not able to capture who was interested in this resource in the electronic medical record. And so while they were avoiding the stigma associated with screening, they also may have missed out on the opportunity to connect, to notify parent care providers of the need that they were aware of in the emergency department. And then another really exciting program, spearheaded by Dr. Cullen as well, was the Complete Eats program in the emergency department at CHOP. And so this provided free summer meals for children in the pediatric ED. Essentially, CHOP became a site for the USDA summer food services program, which is an already existing but underutilized resource in Philadelphia. So patients and their siblings were eligible to receive the free summer meals between the hours of 10 a.m. and 2 p.m. in the emergency department during the summer months. And along with the meal, individuals also received a brochure of other places where they could access the USDA Summer Food Services program in their local community. During the pilot period, their direct costs were pretty minimal, as the food items themselves were part of an existing program that was funded by the government. And the program has expanded quite a bit since that time and now has expanded to outpatient clinics as well at CHOP. So overall, in the initial work from the study, demonstrated that this program was both feasible and beneficial to families. So in the table here, we can see that there was, the food was distributed to many patients, that there was a high comfort with the program in terms of the caregivers receiving these meals, and that the vast majority of those who received the summer meals in the ED were actually not aware of this program that existed already in their local community. So what this suggests is that the emergency department-based interventions can also potentially have an impact in increasing awareness of other resources outside the ED, which I think is a really powerful aspect of this program and some of the others we talked about, and addressing the fact that lack of awareness is a reason for underutilization at times. So a few considerations when it comes to these medium touch interventions. First is the consideration of whether services and resources are offered to all patients versus having either referral or screening to determine who is eligible for these resources. And so as we talked about, the pros of the first approach is to avoid stigma associated with potential screening questions. But then there's a question of how you're capturing a need for connection to other resources as well. A second consideration is that the resources and funding for each of these programs varied quite a bit. So we saw that the startup costs for something like the BMC rooftop farm were considerable, although then was able to generate quite a lot of produce each year. And then similarly, the two food pantries that we discussed had different models, the Louisville one being more expensive in terms of actually acquiring the food. The final point is that emergency department-based interventions, as we talked about, can have an impact in connection to additional resources outside of the ED and increase awareness and utilization of these resources. So that's something that was, I think, really importantly incorporated into multiple of these programs. So the food pantry in Louisville included the list of brochures to other resources for those with food insecurity. And then as we talked about, the summer meals program also open the opportunity for individuals to go to obtain similar meals in their local community through the same program run by the USDA. So with that, I'll pass it off to Lindsay to talk about high-touch interventions.
All right. Okay, so we're now going to transition to an overview of more resource-intensive, or heavy touch as we call them, solutions to addressing food insecurity in the emergency department. In this section, I will be discussing the utility of community health workers, as well as the role that we can have as ED physicians in inciting and being involved with policy change. So community health workers are public health workers that are trained to provide culturally appropriate education and outreach to patients in a variety of settings, including but not limited to the home, schools, clinics, shelters, and other community-based settings. They may also provide services such as counseling, care coordination, and health screenings. So I wanted to give a few examples here of some community health worker-led initiatives. So moving from left to right, we have facilitating access to produce through farmers markets. Sorry, just scroll down. And then increasing access to markets that accept SNAP, where shoppers can exchange an EBT amount for market tokens to purchase fresh produce in farmers markets. They have also collaborated with large-scale organizations such as the National Institutes of Health to create educational materials on healthy eating. And then finally, on the far right, promoting the development of community gardens like the one seen here at the East Boston Health Center. Research has shown that community health workers can significantly impact their communities. So this is one study in particular that I wanted to highlight out of the University of Pennsylvania. This was a multi-RCT study conducted to analyze the effects of a standardized community health worker intervention on hospitalization rates. This was done between 2011 and 2016 in a high poverty, predominantly Medicaid-insured area of Philadelphia. And this study found that standardized community health workers, the intervention reduced total hospital days and hospitalizations outside the primary health system among a population of socioeconomically disadvantaged patients with multiple chronic conditions. So in summary, the study showed that community health workers can have a large impact on healthcare utilization and outcomes. However, at this time, we can use this data only to make indirect conclusions about the relationship between community health workers and food insecurity. So that's one area for further research and potential improvement. So as we learn more about the roles of community health workers within our evolving healthcare system and within the field of emergency medicine in general, it's important to present a framework for their sustainability going forward. So in the future, we must recognize that community health workers, the relationships with their clients is different from the traditional patient-provider relationship that many of us are familiar with. These community health workers often work outside of the clinical setting, and their role may go beyond the scope of an official job title. Second, expanding community health worker integration within medical and public health initiatives is recommended. According to a study done by the Centers for Disease Control and Prevention in 2018, community health workers were interviewed and felt that their involvement in many community health projects were sometimes an afterthought rather than being incorporated and involved in strategy and budget planning from the beginning of a project. Third, promoting partnerships between community health workers and community-based organizations, which are nonprofits that represent a community or a significant segment of the community, is also recommended to promote long-term sustainability. And finally, job longevity has been a major challenge for community health workers, as compensation is often acquired through short-term funding or grants. So moving forward, considering giving more thought to how institutions can retain community health workers and provide adequate compensation is recommended. Finally, I'm going to discuss how we as ED physicians can intervene through policy and advocacy work to further address food insecurity among our patients in the emergency departments. Research has shown that food insecurity is impacted by social intervention, and I want to bring your attention to this figure illustrated here. This was taken from the annual U.S. Department of Agriculture survey on food insecurity from 2022. This showed that the prevalence of food insecurity did decrease from 2020 to 2021, which was likely due to pandemic-specific social interventions. Specifically, there were a few to mention: the suspension of work requirements in the food stamp program and extra SNAP benefits that were available to a number of families and households in the United States. But once these interventions expired, there unfortunately was an uptick in prevalence of food insecurity in the later survey. So as physicians, we can advocate for policies and implement changes that address food insecurity at a variety of different levels. So just to highlight a few areas for involvement as we move forward in our work. Advocacy groups are a great way to get involved. So just to mention a national level one, the Hunger Free America focuses on raising awareness about the effectiveness of federal nutrition assistance programs such as SNAP and WIC, which we've talked about, school lunches, summer meals to improve health. And then, we come from Massachusetts and the Boston area, so highlighting just examples of local organizations. Some Food is Medicine Massachusetts is a task force of clinicians and experts that get together to develop nutrition education models, best practices for food insecurity screening, and how to have a referral system within the state. Policy writing is also an effective way to be involved, and this can be done at both the national and the more local or state level. So ASAP is a great way to get involved to help write policies to highlight scopes of issues being addressed. And then in our neck of the woods, the Massachusetts Medical Society has some food insecurity initiatives. And what's specific to the Mass Medical Society is they do a lot of cross-collaboration with other specialties such as internal medicine, pediatrics, et cetera. And then finally, a motivation to continue our own self-education on these topics, and there are different ways that we can do that. One to highlight specifically is the American Medical Association. They offer continuing medical education courses on nutrition and health, and they specifically have modules on food insecurity that are available to physicians. And with that, I will turn it over for reimagining outcomes in SDOH research.
Sure. Okay, so throughout this discussion, we've been talking a lot about what is food insecurity, what is it that we can do within our practice settings in terms of intervening in the emergency department. We spoke about 3 different levels, from light touch interventions of screening and providing referrals to more medium touch and making co-locating services and programs within the emergency department or in the clinical setting, and then higher touch interventions, including navigation, individualized navigator-based support, whether that's through community health worker, social worker, or other. Through all of this, part of what I think that we have grappled through in the years is, what do we use in terms of our evaluation metrics and outcomes? And a lot of that depends on the level at which we're intervening. So this rainbow figure that you see on the slide here is an adaptation of a pre-existing framework in order to consider the multiple socioecological levels that we can intervene, from the child at the core to the family, the community level and more population level, as well as all of the different levels of impact and outcomes that we can have. So I probably should have stood up so that I can read this off the slide, but I'll go walk over. So in considering the behavioral, built environment, biological, cultural environment, and healthcare system levels at which we can intervene, and then consideration of the health outcomes and how those vary based on each ecological level of influence as well as the level of the intervention, whether we're affecting change at the individual level or more of the community level, changing the structures, where we're creating opportunities for more healthy food to be available in the community, et cetera. So too often, we think that the outcomes that have been measured in studies of interventions in the clinical space for food insecurity or other social factors are focused on health outcomes that may be far too distal for us to actually make tangible change at. So considering what are these other types of outcomes that we would be able to measure that are a little bit closer to patient care and patient-centered metrics.
So this is important from a research perspective because you want to have outcomes that are relevant for your study and also relevant to your patients. But it's critically important from a policy development and evaluation perspective because if you pick the wrong metric, then you're going to set your program up to look like a failure from the very beginning. And the common place where people run into trouble with this is that they say that they're going to give out food and they're going to decrease ED utilization. And that's doesn't really have a perfect causal pathway that's going to necessarily be successful. Gia talked about for the diabetics that maybe food can help blunt some of that monthly cycle of hypoglycemia at an enormous population level. But for any individual ED patient, the point of giving them food is to reduce the fact that they're hungry and help them not be hungry anymore and help their health outcomes be better. And it's not necessarily to have them come to the emergency department less. And in fact, as we think about moving from food to other types of transportation and social interventions, it may actually be that patients come to healthcare more because we're reducing some of these other barriers. We've given them money for food, now they have money for transportation to get to the doctors. So you have to be really thoughtful when you're designing these programs that you're not creating a metric that actually is going to be effectively a failure of your program, and that you're thinking about an outcome that is relevant to your health system, but also an outcome that's going to be relevant to your patients, and an outcome that you think you can actually impact by the food distribution that you're able to do within your system.
The point that Maggie just made about potentially incentivizing ED revisit, I would just challenge everybody moving forward to consider this not as a failure of your program, but actually, is this a benefit? Should we try to create a situation where we are developing a supportive environment that's addressing unmet social need or social factors in general from our clinical setting while we're working to reconnect people back to the programs or wealth that already exists within their communities? So just echoing the critical need to think about these outcomes from the point of developing interventions at the outset.
So as Dr. Ahmad warned you guys, we're going to transition into our smaller group session. So we are going to move up to these front chairs. If you guys could also come to meet us in the middle, that would be fantastic.